Welcome to the deep dive. We're here to help you get a really solid handle on bronchiectasis and do it quickly.
Exactly. Think of this as your high-yield sprint through the absolute essentials.
Perfect for study, perfect if you just encounter this. Our mission today
Is basically to pull out all the exam-relevant gold from these revision notes on bronchiectasis.
and make it stick.
Make it really memorable for you. Yeah. Let's get started.
All right, let's dive right in. So, first things first, what exactly is bronchiectasis?
Okay, so bronchiectasis is a chronic lung condition. The key thing is permanent widening and damage to the bronchial tubes.
Permanent widening. Okay. And that causes problems.
Big problems, because that damage, it impairs the lung's ability to clear mucus effectively. You know, the normal sweeping mechanism. It doesn't work so well.
So the airways get dilated, they get wider, and they can't shift the gunk out properly. Is that it?
That's it in a nutshell.
Yeah.
And because that mucus clearance is poor, you get this cycle of recurrent respiratory infections.
Ah.
And over time, all that ongoing inflammation causes the walls of these already widened airways to thicken up.
So it's like a vicious cycle. The damage makes it hard to clear, which leads to infection, which causes more damage.
Spot on. It just keeps going. Damage, poor clearance, infection, more inflammation, more damage.
Got it. Now, the notes mention different shapes: cylindrical, varicose, saccular. What's that about?
Right, those are morphological forms. It's basically how the damaged bronchi look on imaging, usually a CT scan.
Okay.
Cylindrical is just a simple sort of tube-like widening. Varicose looks more irregular, a bit like varicose veins, sort of beaded.
Huh.
And then saccular, or cystic, that's the most severe form. You see these clusters of cysts or sacs. That one's often linked with cystic fibrosis, worth remembering.
Okay. Saccular cystic fibrosis. Good link. And severity is assessed on CT.
Yeah, radiology tells us how bad it is. And when we manage it, we're really focusing on clearing that mucus, hitting infections with antibiotics, and crucially, trying to sort out any underlying cause.
Because it can lead to long-term lung function issues.
Definitely. Reduced lung function is a major outcome.
Okay, clear picture. Let's talk about the causes then, the etiology. What drives this?
Well, there's quite a range. Infection is a big one, obviously.
Right.
Also, if the host immune response isn't up to scratch, that's a factor.
Makes sense.
Then you have structural things like tracheomalacia or bronchomalacia, where the airways are kind of floppy, or any kind of blockage, a focal airway obstruction.
Okay. What about smoking? The notes say it's not an independent risk factor, but stopping is crucial. How does that work?
Yeah, that's an important point. Smoking might not directly cause bronchiectasis in everyone, but it absolutely makes it worse if you have it. It damages the lungs further, hinders clearance, impairs healing. So yeah, quitting is non-negotiable, really.
Gotcha. And genetic links, you mentioned cystic fibrosis.
Yes, CF is a major one. Also, primary ciliary dyskinesia, or PCD, that's where the cilia, those little hairs lining the airways that sweep mucus, don't work properly.
So genetics can definitely play a part. What about specific bugs? Which infections are the common culprits we need to know?
The most common bacterial offender, the one you see most often, is Haemophilus influenza. Remember that one?
Influenza.
Okay. Then you got Pseudomonas aeruginosa, that's often associated with more severe disease. Also Klebsiella species and Streptococcus pneumonia.
Any easy way to remember those?
Well, maybe think Hep PS, Haemophilus, Pseudomonas, Strep. Just a quick way to recall some key players.
GPS. I like it. And the notes listed even more specific causes. Seems like a lot.
It really is. Actually, the most common cause overall is post-infectious bronchiectasis.
Post-infectious.
Yeah, often following bad childhood viral infections or TB or bacterial pneumonia. That accounts for a huge chunk.
Wow, okay.
Then you've got immunodeficiency like HIV, connective tissue diseases, rheumatoid arthritis, Sjogren's, SLE, even things like Ehlers-Danlos or Marfan's.
Yeah.
Allergic bronchopulmonary aspergillosis, ABPA, usually in people with asthma or CF. Gastric aspiration, so stomach contents getting into the lungs.
Oof.
Congenital defects beyond CF and PCD, like alpha-1 antitrypsin deficiency, yellow nail syndrome, obstruction from, say, a tumor, swollen lymph nodes, or an inhaled foreign body. And even inflammatory bowel disease has links.
That is a very broad list. So thinking about risk factors then, who is most likely to develop this?
Well, building on those causes, anyone with a history of those severe or recurrent chest infections is definitely at higher risk.
Makes sense.
And people with underlying conditions like cystic fibrosis, obviously, or any kind of immunodeficiency.
And environmental stuff? Smoke, pollutants?
Yes, definitely. Chronic smoke exposure or exposure to certain occupational pollutants or chemicals increases the risk. Chronic aspiration is another one. ABPA, PCD, those connective tissue disorders we mentioned, IBD, HIV, they all increase susceptibility.
And it mentioned young children.
Yeah, sadly, young kids who get repeated severe lower respiratory tract infections seem to be at higher risk of developing bronchiectasis later on.
Okay, so it's a mix of past lung hits, underlying issues, maybe some environmental factors. How does the damage actually happen, the pathophysiology?
The core problem is damage to the bronchial walls. They lose their elasticity, their springiness,
Right.
and that directly impairs mucus clearance. The mucus just kind of sits there.
It becomes a breeding ground.
Exactly. Perfect for bacteria.
Yeah.
So you get bacterial growth, which triggers chronic inflammation, and that inflammation damages the walls more, leading to that permanent dilation. It feeds back into itself. Poor clearance, bacteria, inflammation, more damage, more dilation. That vicious cycle again.
The airways get stretched, lose their recoil, can't clear stuff out.
Precisely. And the constant presence of bacteria just keeps the inflammation going, worsening the whole situation.
Okay. So when you're seeing a patient with these kinds of symptoms, what else might be going on? What's in the differential diagnosis?
Good question. Lots of things can mimic bronchiectasis. COPD is a big one, asthma too,
Yeah.
cystic fibrosis and primary ciliary dyskinesia, of course. ABPA needs consideration.
Infect.
Yet, active TB needs ruling out sometimes. And think about things causing chronic cough too. Chronic sinusitis, upper airway cough syndrome, maybe reflux causing cough, pneumonia itself, pulmonary fibrosis, lung cancer, even an inhaled foreign body could present similarly initially.
So careful workup needed, definitely. How common is this condition? What's the epidemiology look like?
Well, in the UK, the prevalence is estimated around 1 per 1,000 people, but it's thought to be underdiagnosed,
Probably more common than we think, then.
likely. And it gets more common as people get older. Also, it seems to be more frequent in women than men.
Interesting. Older age and female sex are risk factors.
Yeah. The inflammation is mostly neutrophilic, lots of neutrophils involved. Prevalence really climbs after age 60. Sadly, it does contribute to mortality, about 1,000 deaths a year in England, and Wales are linked to it.
Wow.
And while it can show up at any age, it's particularly common in older women. Some studies suggest up to 70% of cases are in women, often presenting later in life.
So not just a childhood thing left over. Okay. How does it actually look when someone presents? What are the classic signs and symptoms?
The absolute hallmark is a chronic cough. And not just any cough, usually a productive one, often bringing up large amounts of thick, purulent, meaning pus-like sputum.
Okay. Chronic productive cough. What else?
Recurrent chest infections are very common. Shortness of breath, wheezing, sometimes chest pain, fatigue is a big one too, and sometimes haemophilus, coughing up blood.
Significant symptoms. Are there any really classic features to lock onto?
That persistent, daily productive cough is probably the key thing. Plus the breathlessness, wheeze, chest pain. Patients often notice their sputum gets darker or increases in volume during flare-ups, exacerbations. And that history of multiple chest infections is a red flag.
And diagnosis is clinical plus imaging.
Exactly. The clinical picture, especially that cough, points towards it. But you need that MD-CT scan, the high-res CT, to confirm it by showing the airway dilation. And interestingly, where the bronchiectasis is located on the CT can give clues to the cause. Like central might suggest ABPA, upper lobes could be CF, middle or lower lobes maybe PCD, lower lobes often idiopathic.
Useful pointers. What about listening to the chest? What signs might you find on examination?
Coarse crackles are pretty common, maybe heard in about 70% of people, often early in inspiration, often in the lower zone.
Crackles. Okay.
You might also hear large airway rhonchiac, those sort of low-pitched snoring sounds in maybe 40-ish%, and wheeze in about a third. Clubbing of the fingers, often linked with lung disease, is actually quite rare in bronchiectasis.
Good to know. So cough, sputum, infections, maybe crackles. Now, investigations. How do we nail the diagnosis?
Radiology is key. You'd start with a baseline chest x-ray, but it can be normal. The gold standard, the test you really need, is the high-resolution CT scan, the HRCT.
HRCT is the gold standard. What does it show?
It clearly shows the bronchial walls being dilated, widened. It shows they don't taper normally as they go further into the lungs, and the walls often look thickened. The extent on HRCT often correlates with how bad their airflow obstruction is on lung function tests.
Do you need to repeat HRCTs regularly?
Not usually. No. Routine repeats aren't generally needed unless something specific changes clinically.
Okay. What about the sputum itself? Microbiology.
Oh, absolutely essential. You need to get sputum samples from all patients if possible. These to get to the lab quickly, too, especially to catch bugs like H. influenza or Strep pneumonia.
Why quickly?
They can be a bit fragile, die off if the sample sits around too long.
Okay.
And if you persistently find Staph aureus, or especially Pseudomonas in kids, that might make you think more strongly about underlying conditions like CF.
Right. And blood tests, what are we looking for there?
Standard stuff like a full blood count, looking for signs of infection or maybe anemia of chronic disease. Then, crucially, serum immunoglobulins, IgG, IgA, IgM, and protein electrophoresis. We need to check for immune deficiencies.
Makes sense, given the causes.
Yeah. And maybe serum IgE and specific allergy testing, thinking about ABPA.
Do you always need deeper immune function tests?
Not always, but you'd consider it if there's a strong suspicion of antibody deficiency, maybe recurrent serious infections, a family history, or finding really unusual bugs in the sputum.
Okay. What about other tests? GI stuff, CF screening, ciliary function?
Yeah, sometimes. GI investigations, like checking for gastric aspiration with pH monitoring, might be relevant, especially in kids or maybe post-transplant patients.
Okay.
CF screening is generally recommended for all children and adults up to age 40 diagnosed with bronchiectasis.
Right.
And ciliary function tests. Definitely consider them in children if there's no other clear cause, especially if there's a history like neonatal breathing problems or dextrocardia, heart pointing the wrong way.
In adults?
In adults, think about ciliary testing if they have chronic sinus or ear problems, middle lobe predominance of the bronchiectasis, infertility, or, again, dextrocardia. These can all be clues towards primary ciliary dyskinesia.
Okay. What about lung function tests? Spirometry?
Essential for assessing severity and monitoring. We measure FEV1, FVC, usually in kids over 5 and all adults, peak flow too. Repeat assessments are important, especially if they're under specialist care or have immunodeficiency. Sometimes check for bronchodilator reversibility, maybe exercise tests.
And bronchoscopy. Going in with a camera, is that routine?
Not routine for diagnosis in adults, no, but it has its place. In kids, maybe if it's just one lobe affected or you suspect they inhaled something. In adults, you might use it if the disease is very localized to rule out a blockage, or if someone's not responding to treatment and you can't get a sputum sample, or maybe if the HRCT suggests atypical mycobacteria but sputum tests are negative, or you need samples to check for aspiration.
Okay, so selective use for bronchoscopy. We've diagnosed it. Now, management. What are the main goals?
Two main goals, really. One, decrease the inflammation in the airways. Two, manage the infections effectively.
How do we do that? Meds.
Meds are part of it. Eucalyptics can help thin the mucus,
Yeah.
make it easier to clear. Things like carbamazepine or hypertonic saline sometimes.
Okay.
And preventative therapies are key treating any underlying cause you find. So specific antibiotics for NTM infections, IVIG if they have an immunodeficiency, steroids, and maybe antifungals for ABPA.
And for the acute flare-ups, the exacerbations, antibiotics then?
Absolutely. That's a mainstay, usually a 10 to 14-day course. Ideally, you guide it by the sputum culture results, if you have them.
What are the common choices?
Often start with things like amoxicillin or doxycycline or clarithromycin, depending on local guidelines and patient factors. But you adjust based on resistance patterns.
What if someone keeps getting exacerbations?
Yeah, for recurrent flare-ups, long-term antibiotics might be considered. Often low dose, sometimes rotating. Again, you try to tailor it to the bugs they grow. Keep doses reasonable, and watch carefully for resistance developing. You wouldn't change it unless they're clearly not getting better.
Okay. What about non-drug approaches? Physio seems important.
Hugely important. Airway clearance techniques are fundamental. This is usually led by respiratory physiotherapists.
What does that involve?
Various things. Specific breathing techniques, using gravity-assisted positions, maybe manual techniques like percussion, using devices like a cappella or flutter valves. Sometimes inhaling nebulized saline helps loosen things up. Pulmonary rehab programs are great for managing breathlessness and improving exercise tolerance.
And other non-drug things.
Managing other issues like swallowing problems or reflux is important. Lifestyle is massive, healthy diet, staying active, absolutely stopping smoking, and getting the annual flu jab and the pneumococcal vaccine.
Makes sense. Surgery. Is that common?
Not common, but it has a role. Sometimes, if the disease is very localized to one area and causing lots of problems, they might consider surgically removing that lobe, a lobectomy. For severe hemoptysis, coughing up lots of blood, procedures like bronchial artery embolization to block off the bleeding vessel, or sometimes surgery, might be needed urgently. And for very severe end-stage disease, lung transplantation is an option for carefully selected patients.
Right. So a really comprehensive approach needed. What's the long-term outlook? The prognosis?
It's definitely much better than it was before antibiotics. Back then, death within 5 years was common.
Thankfully not like that now.
No.
Yeah.
But it still often leads to a significant reduction in life expectancy compared to the general population.
That's significant.
Figures vary, but maybe around 10% of adults with non-CF bronchiectasis might die within, say, 5 to 8 years of diagnosis. Respiratory causes are the main driver, over half the time.
That's still quite serious.
It is. But things like good nutrition and getting those vaccinations really do seem to improve survival.
What factors suggest a worse prognosis?
Things like having low oxygen levels, hypoxemia, high carbon dioxide levels, hypercapnia, how severe their breathlessness is, and how widespread the disease looks on the CT scan, they all correlate with higher mortality.
Okay.
Also, being chronically colonized with Pseudomonas aeruginosa is generally a bad sign. Frequent severe exacerbations and signs of ongoing systemic inflammation, like a high CRP level in the blood, are also linked with faster progression, especially in non-CF bronchiectasis.
Right. And what are the main complications people can run into?
Well, the big ones are those repeated infections and the steady decline in lung function over time.
Expected, yeah. Anything else?
You can get complications like empyema collecting around the lung,
Yeah.
lung abscess, pneumothorax, a collapsed lung, sometimes triggered by severe coughing fits.
Oh.
Life-threatening haemophilus, as we mentioned, eventually respiratory failure, right heart failure or cor pulmonale from the strain on the heart, rarely a condition called amyloidosis. And then there's the big impact on quality of life, the fatigue, the social embarrassment from the cough and sputum, anxiety, depression, sometimes even things like urinary incontinence from the chronic cough.
It really impacts multiple aspects of life. So a serious condition needing prompt diagnosis and thorough management.
Absolutely. Catching it early, identifying and treating any underlying cause, that's really key to trying to manage it effectively and improve the outcomes for patients.
Okay, let's try and summarize this deep dive then. The key takeaway for bronchiectasis.
I'd say it's that chronic condition involving permanent airway damage. That leads to poor mucus clearance, setting up that cycle of chronic infection and inflammation. Management needs to be multifaceted, clear the airways, treat infections, address the root cause if possible.
And we've hit the main points from the notes definition: causes, risks, how it happens, what else it could be, how common it is, how it presents, how we investigate and manage it, and the outlook and complications.
Pretty much covered the essentials there, yeah. All the high-yield stuff you'd want for exams.
Okay, here's a final thought for you, the listener, to mull over. Think about how all those different causes and risk factors we discussed, infection, immunity, genetics, environment, can actually overlap and interact in one single patient. It creates a really unique clinical picture each time, doesn't it?
It really does. It underlines why that careful evaluation and personalized management approach is so important. And for more high-yield resources, definitely check out pastthemsra.com.
And free MSRA.com for more great prep materials. Thanks for joining us on the Deep Dive.